The following podcast is part of a certified educational activity titled Transforming Care and Outcomes with Immunotherapy in Stage 1 to 3 Resectable Non-Small Cell Lung Cancer, a case exploration of new standards and emerging approaches. Access the entire activity and complete the post-test at peerview.com/WFQ860. Downloadable slides and practice aids are also available.
Welcome all of you to Transforming Care and Outcomes with Immunotherapy in Stage 1 to 3 Resectable Lung Cancer. We're going to try to do this with a bunch of cases today and just a brief review of the evidence in the space. I'm Jessica Donnington. I'm a professor of surgery at the University of Chicago. And I think my colleague here, everyone knows Dr. Jonathan Spicer from McGill University. He really has become the king here on the perioperative immunotherapies. Our goals today are to enhance your understanding of the latest evidence supporting the use of immunotherapy for resectable lung cancer, to augment your skills in identifying candidates for neoadjuvant, adjuvant, or perioperative immunotherapy, and improve the multidisciplinary collaboration to integrate these regimes into care for resectable patients. We are going to kind of briefly run through the evidence in this area and then go through cases with a lot of emphasis really more on the cases than the evidence. So obviously lung cancer is a big problem. Not only is the incidence high, but the real problem lies in the mortality associated with the disease. And worldwide, 1 in 4 cancer deaths is a lung cancer death. And the problem really isn't just stage 4. Let's face it, resectable disease has pretty dismal survivals also. In the last staging group, we saw survival somewhere between 37 and 71% for stage 1B through 3A. Not something to be particularly proud of. And I think the real issue is that when you see this patient in your clinic, a patient who shows up with localized disease and lymph node involvement, the reality is that 2/3 to 3/4 of those patients are really this patient. And they already have micrometastatic disease. And all the good local therapy in the world, your magical surgical hands are only going to treat the disease we can see. And we really have to think about systemic therapy to take care of that micrometastatic disease, which is already there when you meet these patients. Luckily, in this space of stage, what was 1B, but now stage 2 to 3, we have seen so many advances in the last 4 years. I came into thoracic surgery in 2000, and in 2005, we introduced adjuvant therapy. But I have to tell you, it was pretty meh. I don't think people really were super excited. It was a 5% benefit, and you were giving them platinum doublet chemotherapy. But the reality is, since 2005, we have a ton of better agents. We have way better selection. I mean, adding things like PET, EBUS, and molecular testing. And we even have really significantly better surgery. And I think all of us are hoping that this next round of adjuvant and peri-adjuvant care really has far better outcomes. So when we talk about how to incorporate immunotherapy into the resectable space, I think it gets down to these 5 steps. We need to select the appropriate patients, determine the sequence of therapy. We have to do appropriate pre-op and intraoperative nodal staging. We have to understand the evidence because we need to relay that evidence to our patients. And we need to plan for the potential technical challenge which might be happening, especially with neoadjuvant and peri-adjuvant therapy. So how do we select the correct patients? Well, right now in early stage lung cancer, we have kind of 2 very separate worlds. We have that which goes to a targeted therapy. Luckily for us as surgeons, we only need to know 2 targets. But that is now mutually exclusive from those patients who should be seeing immunotherapies in the form of checkpoint inhibitors. That means how we work our patients up past a 2-centimeter tumor really has to change. It is no longer just about staging and physiologic assessment. We have to be thinking about biomarker analysis. And at minimum, we need an EGFR, we need ALK, and we have PD-L1. And whether those are done as standalone tests or as part of NGS, this needs to be done. Again, for anyone with a tumor greater than 2 centimeters, you have to be thinking down this path. Sequencing. If I had the answer of where and how to put these in place, I would have a new job and make a lot more money. But it's really complicated, and I don't think we know for every patient what the best sequence of therapy is. I think there are some basic considerations. In the neoadjuvant space, it's about eradicating micrometastatic disease and getting there sooner. But I also think with the immune checkpoint inhibitors, it might be about having that primary tumor in place to really teach the immune system what to do and what to look for. Obviously, the adjuvant space for a surgeon is really attractive. I don't have delays. I don't actually have to do biomarker testing before, because I'm going to give you a whole big tumor for biomarker testing. And maybe most importantly, I don't have to worry about delays and fibrosis and attrition, all those things that really are harder for surgeons. I think the sandwich therapy is the best and worst of both worlds. It's the most bang for the buck, it's the most treatment, but it also comes with a lot of treatment for patients, a lot of risk for attrition and falling off. And again, we may have to decide which patients need all of it. I can't say enough about nodal staging. This is taken from the recent AATS guidelines on the treatment of early stage lung cancer. And you know, those first two things are all about appropriate staging preoperatively and appropriately staging the patients intraoperatively. If you don't stage those lymph nodes, you don't give the patient the opportunity to get these therapies. And I think we really have to think about that, the opportunity for them to get this additional treatment, which benefits their survival. All right, understanding the evidence. This is where it gets super hard, and that's because we've had, somewhere in the range of 9 major trials report out in the last 3 years, and the evidence changes on a weekly basis. Within the adjuvant space, we've seen 2 major trials, and there are a whole bunch who have not reported out yet. In the neoadjuvant space, it's really just the CheckMate 816. It's the only trial in this space as a purely neoadjuvant. And then the periadjuvant space, that has been the hot spot in the last couple of years, with the GN Neotorch, Keynote, CheckMate, and Rationale all reporting out in the last 12 months. So super busy slide, but these are all these trials, and kind of broken up by the space where they're used. And I think I want to really highlight how similar they are. And that might be my theme on all of this review through the evidence, is how similar these trials are. And I think that's a good thing. That means that the benefit we're seeing from one trial to the next is real. These are real benefits that we don't think will go away. So the adjuvant trials, they're a bit bigger. They have to be. It's the adjuvant space. Otherwise, all the other trials are pretty similar in size, with the CheckMate trial being a bit smaller. They are all paired with a platinum doublet. The only one that made it optional was the Keynote 091, which was an adjuvant trial. They all have very similar endpoints. Most conclude kind of an event-free survival and a pathologic survival to the end. And most of them, especially as we have matured, have gone to excluding patients who have EGFR and ALK mutations. So again, very similar. I do think the adjuvant trials have more stage 2 than stage 3 patients in them. That's kind of expected for how we treat our patients. This is a little confusing, these little bar graphs. The top bar for each trial is the length of treatment. And you can see my selling point to patients when I tell them they should go on CheckMate 816. What is it? 3 cycles. You just need 3 cycles. All the others, it's a commitment, a year-long commitment or more to treatment. And if the patients need it, that's perfect. But I think that's important to note. The bottom bar is the current length of follow-up, how long these trials have been following their patients at the point of reporting. And again, we can see the longest by far is for CheckMate 816, but it's not at 5 years yet. We haven't made it to 5-year overall survival. And some of these trials, a GN Neotorch, less than half of the patients have completed their therapy before they reported out data. So I do think in the perioperative trials, maybe it's the pathologic data, which is really most important, and we don't know the full survival benefit of what they received after surgery. So again, now comparing the pathologic evidence from the neoadjuvant and periadjuvant trials. And you can see in terms of path-CR, really at least a 4 to 12-fold increase in pathologic complete responses from the chemotherapy to the chemotherapy plus immunotherapy arms, and a pretty similar uptake in every single trial. And similar for the major pathologic responses also. So I think this is, again, this is good. This is consistent. This stuff clearly works. I do want to highlight the difference between the Checkmate 816 and the Checkmate 77T. 3 cycles versus 4 cycles, although Patrick Ford will tell you it was really 3.5 cycles since not everyone got that 4th cycle. But I don't see a significant uptick in the efficacy of the therapy with that cycle. So again, asking that question, how much therapy do they need or not need? And these are the 2-year event-free or disease-free survival for those. Again, so the adjuvant trials use disease-free survival, and the neoadjuvant and periadjuvant use event-free survival because not going to surgery was an event. And you can see that they're all fairly similar. The hazard ratios are similar. The difference here, the NeoTorch trial and periadjuvant, hazard ratio of 0.4, that was just for a stage 3 population. We expect a more dramatic impact there. Otherwise, they look pretty similar. And again, the adjuvant space, harder to prove a benefit, especially if it's dominated by stage 2. The Checkmate 77T is highlighted different just because we've only seen 18-month data and not 24 months yet. And then this is the overall survival benefit that has been reported so far. We've only seen that reported for Empower, Checkmate 816, and Keynote 671. Statistically significant survival benefit is only for the Keynote trial. The others look similar, but the Checkmate trial was much smaller, so therefore not statistically significant yet. And again, adjuvant, a much harder place to prove benefit than in the neoadjuvant space. So I don't think that, again, I think the agents work, but just how we prove benefit in the different spaces is hard. I don't think we can ignore technical challenge. You know, the difference between a virgin chest and a chest that's undergone neoadjuvant treatment, I think all of us would agree is different. Here's work from Cornell and MD Anderson that says, yeah, guess what? We all knew it was different. It also says the Cornell group, it's not worse than chemo alone to add immunotherapy. It doesn't look any worse. And then the MD Anderson group tells us that it's about 1/3 of their patients are bad, and we don't know how to predict who that group is yet. The MD Anderson group did go on to look a little bit deeper at their neoadjuvant populations to try and tell us who is that really bad population. Now, this was primarily a chemotherapy series, but the 2 things that they really pulled out, which I think in my own work I recognize now, after I read this paper, was those patients who had clinical N1 disease, maybe more than the N2, and those patients who had a really good response to therapy as those that had more complex and more challenging resections. And this is one of my cases that I remember I did right after I read that paper. And, you know, a patient with a nice right upper lobe tumor with significant N1 disease and a really good response. And I thought, oh man, this is it. This is a troublemaker. And so I've written down now how I think about these patients because I do approach all of these patients minimally invasively. But what's different between a regular 1A patient and a post-induction patient is I actually do always discuss the possibility of opening with this population, and it's on the consent. I have open and MIS instruments in the room. I discuss the possibility of opening with the anesthesia team so they know it's a possibility. I actually make sure I have a strong assistant. We have general surgery residents who rotate on my service. And, you know, if it's a VATS right upper lobe, and I think for this case I was given the PGY2, I called my partners. I said, is anyone else around today? Because, you know, I might need some help. I also make sure that I'm not doing something else. You know, I haven't put another case on. I'm not in a meeting. This is all I'm going to do while this case is going on. I always start minimally invasively. I look for disease, and then I just keep going till it doesn't feel safe. And anyone who, well, none of you guys have operated with me, maybe Justin, I'm like a chicken. I'm not a brave person. I get scared by almost anything, and yet you just keep going and going. And I'm at the point where, I don't know, I probably do 75 to 80% of these with a scope. You just go till you don't. When I convert, I convert. I just, you know, I'm a VATS surgeon. I make my anterior thoracotomy a little bigger, put in a bigger wound protector, and maybe a small spreader. I don't think it's a sin. When I leave the OR after I convert, I have to remind myself I didn't commit a sin, that the priority is getting the tumor out safely. So now I'm going to pass the microphone off to Dr. Spicer to go through some of the controversies.
Thanks, Dr. Dottington. I think that's, you set a new benchmark for summarizing the data. That was really excellent. And data there is. You know, it's funny, when I started in practice, I was really pushing for neoadjuvant chemotherapy for my locally advanced patients, and it was a big debate. People would tell me that, well, none of those trials came to full accrual, and there's so much more data for the adjuvant patients. Well, now there's literally thousands of patients that have been enrolled on trials using a neoadjuvant perioperative approach. And so about a year ago, this MD PhD student, Mark Soren, approached me. He's in my lab. He said, I'd like to do a meta-analysis of the work that's coming out. I was like, well, that seems like a good idea. And we happened to try and time it with all the data releases that were coming out. And what we want to do is resolve, I think, two main controversies, and the paper goes into quite a bit more, but the two that I want to clarify are the stage indications for neoadjuvant treatment and the PD-L1 levels. So we wanted to look at stage 2 and 3 because I'd been hearing a lot, both from surgeons and oncologists, generally that they were reticent to offer a neoadjuvant strategy to a stage 2 patient who is eminently resectable. And I wanted to make it clear that there was an EFS benefit for those patients. It seemed obvious to me that there was just a lack of power in all of those subgroups. And you can see that once you put a little over 700 patients together, you have a hazard ratio of 0.71. I'll remind you that that's the threshold at which we recommend the indication for adjuvant chemotherapy. That's the sort of level of evidence that supports that indication. So now not only do we have the benefit of chemo, but we also have an added benefit on top of that of immunotherapy in this setting, and that's quite important. I think there's no doubt in the stage 3 patient with a hazard ratio of 0.54, when you put it all together, over 2,000 patients, that is clearly the way to go. It would be very hard for me to approach a stage 3 patients up front when there was an alternative approach. The other point is about PD-L1 testing. As you may know, the FDA and a lot of other jurisdictions approved CheckMate 816 across all PD-L1 strata, but the European Medical Agency only approved it for PD-L1 positive patients. So that's a lot of people who don't have access, and perhaps people practicing in a manner where they won't offer it to PD-L1 negative. What the data seem to indicate is that while the magnitude of benefit is less, there still is an important one, again with a hazard ratio of 0.74 that's statistically significant. If you want my opinion, there's some good papers about this. If you were to resect all the patients who are PD-L1 negative, you'd see that they're actually positive in a fair number of patients once you resect that specimen. Because it's heterogeneous in terms of its staining, and a blind needle biopsy of the tissue, whether it's the primary or the node, may or may not give you an area of the tumor that is positive. So whether or not the benefit is only to those falsely PD-L1 negative patients, or if some of the true PD-L1 negative patients are also deriving benefit, we don't know the answer to that. But in the absence of a better biomarker to adjudicate neoadjuvant chemoimmunotherapy, I think PD-L1 on its own is not an indicator of whether or not you should consider it. And then overall survival. So is this approach really offering an overall survival benefit? And again, with a little over 1,600 patients, it's very clear that it is. Of course, Keynote 671 demonstrated statistically significant overall survival in the intent-to-treat population, but now with all of these patients put together, the hazard ratio is 0.65, and that's very important, and something that cannot be said on the adjuvant side. We don't have any data on the intent-to-treat basis suggesting that adjuvant IO in a biomarker unselected population improves overall survival, at least not yet. Now, the PD-L1 level is important to consider on the overall survival front. Hazard ratio for the PD-L1 negative on the outcome of overall survival is not statistically significant. It's 0.89. Is this trending, and perhaps after 5 years we'll have a positive outcome, or is it not going to pan out? Remains to be determined. I'll show you a case a little later on that might explain why in some scenarios it's hard to show overall survival benefit in these harder to treat patients. The last piece of data I'll cover here before we go to the cases is this surgical outcomes from Keynote 671, which I don't think I have I have a cursor here. So there's 2 points I want to highlight. So for the surgeons, here we go. For the surgeons in the room, there's really 2 essential things that you can do to make sure the patient has a good outcome. Number 1 is assure that they get to surgery. And that's obviously collaborating well with your medical oncologist, selecting patients who can get through the treatment, who are operable, and you're not going to suddenly change your mind halfway through the course that they're inoperable. You can see the hazard ratio for patients who don't get to surgery, not quite as good as those who do. So we're important, and we're doing something important by resecting the patients. The other piece of data is on R0, so surgical completeness versus R1, R2. And you can see that the patients who derive benefit here are the patients who had an R0 resection. So don't be too aspirational in terms of who you select for surgery. Make sure they are resectable and that you can offer that complete resection, because it continues to be a really critical piece of the puzzle.
All right, so we are going to move to the case portion of the afternoon. Hopefully we like the interactive stuff. So this is a 63-year-old former smoker with a right upper lobe mass, which was found on a cardiology workup. It was about 3 to 5 centimeter central mass. Brushing and biopsies from the outside bronch were negative for malignancy. And they were going to send her home with a 3-month follow-up. But a PET was gotten, and it all had uptake, and she was sent to us. She went for a repeat bronchoscopy with EBUS, and her lymph nodes were negative for malignancy. This did bring up one of the questions about when do I discuss molecular analysis with patients. And I do discuss it on my initial visit for anybody who, in my opinion, needs invasive mediastinal staging. So in our practice, those are patients with tumors greater than 2 centimeters. Or tumors near the central part of the lung. So if I think they need EBUS staging, then I think they need molecular analysis. So you're right, for most peripheral tumors less than 2 centimeters, I don't start that conversation unless I have a reason to biopsy their mediastinum. But once they're at that point, I think it's worth carrying on this conversation about what we're going to do, and that molecular analysis is part of it. So her lymph nodes were negative. But the PD-L1 was 60%. When I measured her tumor in the craniocaudal, it was suddenly not 3 centimeters or 3.5, but it was 4.4 centimeters. So I do, in this group of kind of 3 centimeter tumors, I always look in multiple directions to make sure of how really big the tumor is. So she was a stage T2B N0, a 2A. Her cardiac workup was unremarkable, and she had, very adequate PFTs for resection.
And maybe just a quick question is, does the probability that you think you can get the case done minimally invasive upfront influence your choice to offer neoadjuvant? Like, would you maybe hesitate to give neoadjuvant if you didn't think that you...
I personally wouldn't. I feel like it depends. I should take that back. I think, in cases like this, I think, again, it's that priority of getting them all the therapy they need. So they have to get their surgery, or they have to get their local therapy, and they have to get a systemic therapy. And if I thought that maybe, doing them an upfront surgery and being able to do it minimally invasively might, have a better chance of getting through surgery rather than sending them to radiation or somehow guarantee them getting it, both arms of therapy, then I would think about that. And sometimes big central tumors, you think of things like that. Mm-hmm. But in general, I think it's easier to give therapy before surgery than after. I don't think we're great at after. So this patient did undergo 3 cycles of chemoimmunotherapy, tolerated it well. She had to get a platelet transfusion. But her repeat imaging wasn't super pretty. Sometimes, the tumor shrinks out, and sometimes it shrinks in, or sometimes it grows and goes in. And hers kind of got bigger and went in. And now the tumor looks like it was part of that lymph node mess, and it's not all so nice anymore. So we went to the OR, we did a right VATS, we had to lay some adhesions, but she got a right upper lobectomy. I didn't have to open, surprisingly, because it looked like it was going to be terrible, and it actually wasn't so terrible, so I can't predict. I'm bad. But pathology comes back. She's a path CR, no residual viable tumor. She did have a chyle leak. I'm not surprised. That was a big wad of lymph nodes I took out of there. But luckily, it got managed conservatively, and she went home on post-op day 7. That's, again, a sacrifice I'll take. But I have to tell you, this is one thing I love about the neoadjuvant and periadjuvant approach. That past CR is like, yes. You know, we can look at these patients and tell them their cure rate is like greater than 90%. We don't do that for stage 1. It is, in my opinion, like such a carrot in my thinking about this therapy.
Just a quick question, going back when you saw that post-induction scan, would you consider restaging at that point, invasive restaging, or what are your thoughts on that whole
I've
piece?
never been a restager since my old days of chemo radiation. I am a, N2 or not, when I make the decision to go, as long as the patient is still fit enough to undergo a resection and hasn't progressed outside the chest, I keep marching. Is that the right answer or the wrong answer? I don't know.
I have the same practice, but yeah, I think it's the way to go.
With the prospect trial or whatever coming up may help us with some of these decisions and better understanding what happens in these cases. Yeah. All right, keep going.
Yeah, sounds good. All right, so I'm gonna, did I leave? Okay, this is my clicker. Apparently we each have our own clicker and we're not to share. Okay, I'm gonna go through 3 cases. Oh, sorry, that's to come. This one here is actually a bit of a change up from what we've talked about so far. This is a 60-year-old woman who had a history of pancreatitis, and on scan, the lower cuts of the abdominal CT showed this lesion in the right lower lobe. You can see it has some avidity on PET. She had good lung function. She was an active smoker. So I have a colleague who will remain unnamed who decided to do a 15-minute wedge resection of this nodule. Unfortunately, no lymph node dissection was performed. The PD-L1 of the resection specimen was 100%. NGS was negative for any mutations or alterations. There's a lot of information in this path report. So it's an invasive adenocarcinoma that's solid predominant. It does have micropapillary component here. We know that that usually comes with a very bad prognosis. It has STAS, even though it's small size, 1.2 centimeters. There's lymphovascular invasion, and there's visceral pleural invasion, which is why it was upstaged to a PT2A. So with that information, this is what the path looked like. You can see the nodule. There's a bit of margin there. This is cancer. It's looking pretty angry. And this is what STAS looks like, where you can see a little cluster of cancer in an alveolus. Now, I had just read this paper before I saw this patient in post-op. It was sort of shared practice model, and seeing her for the first time in post-op, sharing the pathology report with her. And what this paper out of the TRACER-X group was showing is a few pieces of information. One was that STAS was very important for predicting disease-free survival, and obviously ctDNA positivity as well. But what was really interesting is that there was some associations between these combination of factors with the site of relapse. Patients who are STAS positive, ctDNA positive, are most likely to have extrathoracic relapse or combination relapse. But those who are STAS positive and ctDNA negative, well, they had a high rate of intrathoracic relapse. And we kind of know that from some of the other studies looking at sublobar resections in STAS-positive patients, so we know it's an important biomarker. But this concept that it might influence the site of relapse is actually really interesting. And this patient had micropapillary, STAS-positive. This is sort of the genomic features that are associated with that. High rate of intrathoracic relapse. So what should we do for this patient now? I think it's always a difficult decision with a patient to say, go back to surgery. You know, you have negative margins. Maybe you do have a good outcome just with that wedge. Let's go on to the next slide.
A minute here to talk about ctDNA, because the question did come up about whether we use this in our practice to help us decide who needs, adjuvant after neoadjuvant and such. I don't currently use ctDNA regularly. I don't know if you do. I just don't think it's, it's not sensitive enough in early stage disease. So if it hits and you get it, then you're right, this is a super bad player, and that patient you should escalate therapy on. But if you don't find it, I think it's a false sense of security that it's not there. I just don't think that the early stage tumors shed enough for us to reliably know we have it.
Yeah, I completely agree, and it's also a technology that's sort of evolving in leaps and bounds in terms of that point around sensitivity. There's the whole concept of, tumor agnostic versus tumor-informed assays, which still require biopsy. If I were a young resident or fellow getting involved in trials, I would want all my trials to be ctDNA driven, though, because the data are really compelling, and I'm sure that stage 1 disease will increasingly be guided by those types of tools, but they're not for standard practice, I don't believe, at this particular point in time. So I read it similarly to most people in the audience. This patient with very high-risk features. Even if there isn't a super high risk of distant progression, very high risk of local progression based on that TRACERx data. And then I also thought about what this patient could benefit from if we did upstage her at resection. She has PD-L1 100%, so in Canada that means she has access to adjuvant atezolizumab with, I'll show you, a very important overall survival benefit. But she also would, in addition to that, be accessing adjuvant chemotherapy, which currently would not be administered by our oncologist. And she was in good condition. So we went ahead with a completion lobectomy. It was rather uneventful. The lung didn't have actually any disease. This is normal lung. But level 9 had a focus of actually quite a bit of cancer in it. And so final path, once properly staged, that's kind of why we were reinforcing the concept of stage, is a PT2A and 2 stage 3A. And now she's eligible for adjuvant chemo, which has its own overall survival benefit in stage 3, somewhere in the 10 to 15% range, and an added 17% OS gain from the addition of immunotherapy. So this is a patient who's now boosted their survival by well over 35%, which is very good. So let's stage our patients correctly when we're in the OR, even if we're doing sublobar resections, and keep doing the work that we have to do as surgeons properly. Okay, the next 3 cases I'm going to try and go through relatively swiftly. There's some questions along the way because I'm curious to know what you would do. But the point here that I'm going to try and get across is that stage doesn't mean that much anymore. It's more about biology. And stage is just telling you about what the tumor looks like anatomically, but there's a lot more going on. So this is a 61-year-old patient. I presented this case before. She has PD-L1 0%. She's found to have a G12C mutation on the next generation sequencing. So she's clinically staged as T3N1 based on CT, EBUS, PET, and brain imaging. And she's got excellent lung function. You can see the lesion is abutting the interlobar PA, so this is a challenging surgical case. I don't have more images, but just imagine the tumor more progressing cephalad. There was nothing really crossing into the lower lobe. So anyways, we gave this patient preoperative therapy. She was on a trial. She developed COVID after the 2nd cycle, so we couldn't get to 3. This was her restaging scan. You could certainly shrank. And I'll tell you that the PA reconstituted nicely as it progressed into the lower lobe, so I thought there was a target there. And I put myself and the entire OR team, anesthesiologists, through torture after a 5-hour VATS double sleeve. This was the resection. I was very proud of myself. Fortunately, the patient did okay, but I'm not sure that this is necessary, really, or the right thing to do. But here in this patient, remind you, they are, oh, sorry, one more detail. Oh, I can't go back. But it was an R0 resection. RVT, which is the percent residual volume of tumor, we haven't talked about it much, was 61%, so there was a lot of residual tumor here. And I think the pathologist might have been a bit generous with me on the R0 call, but apparently it wasn't going across the ink. She's done well. She now has 2 lungs. She hasn't had a pneumonectomy. I'm going to be a little bit more hesitant about adjuvant IO in a patient who's had a pneumonectomy. And we'll soon see some data, hopefully, in one of the coming meetings about outcomes by pathological response for the perioperative study. So that will be informative as well. Okay, going on to what ultimately happened to this patient is that a year and a half later, she presented with a headache and was found to have an isolated brain metastasis. She was treated with surgery and stereotactic radiation. And because we already knew that she had a KRAS G12C mutation, she was started directly on sotorasib, and now she remains NED 3 years after her diagnosis. And when I mentioned why it can be difficult to show overall survival differences in these early stage trials is because this treatment would not have been available to her when she was originally diagnosed. I like to think that the combination of treatment and surgery prolonged her EFS such that she could access this down the road, and that becomes more and more true as time goes on and more treatments become beneficial. So in the PD-L1 negative cohorts where we're really pushing hard to get new and more effective treatments, when they do metastasize, I think having prolonged EFS is an important outcome for these patients. Okay, second case of left upper lobe tumor, 60-year-old male this time, ECOG 0. It's an adenocarcinoma. Here we have PD-L1 100%. Again, no molecular alterations. It was also staged as T3N1. FEV1, that's after EBUS. The 4L was negative, but there was a highlighter note that was positive. And a little less good lung function, but still a robust patient. This is I think that lymph node was called a 10, even though on EBUS, even though it looks more like a 4L to me. So this patient had a great response to, it was on a blinded trial, so I don't know if, and I still don't know to this day, whether he got IO or not, but he had a remarkable response. And now that lymph node looks like it was probably cancerous because it responded very nicely as well. Well, I started VATS as I usually do, and it was maybe earlier in my experience, and I was really not comfortable progressing through the case. And so I converted to open. We took the superior segment because there was some disease bridging, or what looked like disease bridging, onto the fissure. Bovine pericardial patch, and it's a complete pathological response. Man, am I glad I did not do a pneumonectomy on this patient. And I do think you should open these patients before committing them to a pneumonectomy to be quite certain, and send some frozens along and guide yourself as best you can, because it's not fun to do a pneumonectomy for no cancer left. And he's doing super well. So that's case number 2. Now, case number 3. I'm not so happy with how this one went. And mistakes happen. An 80-year-old patient who I had operated on 6 years prior for stage 1 lung cancer. So he had a right upper lobectomy, and now presents with this new disease. He's 80 now, still in great condition, but it looks like ugly disease in the left upper lobe. Endobronchial biopsy shows squamous cell carcinoma, PD-L1 TPS is 5%. He still has really good lung function, but I personally wouldn't do a pneumonectomy for a patient who's got 2/3 of lung on the contralateral side. This is the disease. You can see it was bridging the fissure a little bit. Now, the problem here is that he saw a multidisciplinary team with, I guess there was a surgeon there, but maybe not as thorough an assessment as should have been made. Maybe because the patient looked really good, maybe because they didn't quite appreciate how significant the fact that he had a prior lobectomy was, even if he had good lung function. He was assigned to neoadjuvant therapy. The message is, make sure you assess your patients yourself that you're going to assign to these treatment strategies and see them through. It's very hard to shift team members because, for one, we all have different appreciations of risk, and for another, it makes it a lot easier for that patient to be seen by the same set of doctors. In any case, he got sent back to me for the resection after completion of chemo-immunotherapy. And I didn't really have the heart to tell him that I didn't think it was a good idea to go to surgery. Maybe I should have, and these are sometimes difficult decisions you have to make. He had done okay with the preoperative treatment. He was still in decent condition. He had sort of a partial response, but not much, to be honest. And so this comes into the play, what's less morbid for this patient? To go to surgery, have a lobe, hopefully, or to go to, 30 fractions of chemo-RT. Neither is a great option after having finished all this treatment, and this is where we have to be cautious with the selection of our patients. Anyways, I took him to the OR. And I hated that operation because your back's against the wall, and we were dissecting lymph nodes that had not responded all the way down the ongoing PA. We did an S6 segmentectomy as part of the en-bloc resection. I was pretty certain I was leaving a microscopic disease at a minimum there. And he was complicated by a bronchopleural fistula, fortunately managed just with drainage antibiotics. The final pathology, and this is the twist here, is that he's T3N2. It's actually more complicated than assumed on preoperative diagnosis. It's an adenosquamous carcinoma. The N2s are positive in some levels for adenocarcinoma and other levels for squamous cell carcinoma. He's got 30% RVT, so he did have a partial response, but most importantly, the NGS reveals that he has MET exon 14 skipping, and this is present both in squamous and adenocarcinoma components. This was not picked up on the preoperative biopsy. And this might be the most useful piece of information that we got out of this, so that when he recurs, he'll have access to useful targeted therapy. So we have 3 cases, one where surgery provided some durable local regional control, but the plan didn't mitigate distant metastasis. We have a 4th case where the surgery confirmed the PCR and gave a great cure, chance of cure to that patient. And a 5th case where surgery was complicated, provide incomplete resection, but did reveal an important tumor vulnerability. So, and they were all T3N1 disease. So it's a lot more complicated than it looks. So key takeaways. The current state of IO is that IO brings benefit to our patients when you do proper biomarker and exclude those who don't benefit. Neoadjuvant chemo-IO is associated with significant improvements in EFS. There's really promising OS data coming forward. The contribution of the adjuvant component remains to be determined. These regimens do appear to be safe, but there is attrition and there is unmet need. We need to better detect micrometastatic disease, talking about ctDNA. We need more consistently testing of comprehensive biomarkers. We need to clarify limits of resectability and safety, and we need better tailored systemic treatments for the complexity of biology that we're facing. These are resectability criteria, and I think they depend on patient wishes, surgeon experience, obviously the objective measurements of function for that patient, but also all the alternatives that exist for those patients, and a careful consideration of those and what the patient might prefer. So I think we have time for maybe a couple questions. Happy to take anyone at the mics, or I don't know. Dr. Donington, if you have any on the...
I can go to the iPad for a couple. One asks about when do I prep my patients about adjuvant therapy if it's a stage 1 patient. I actually do it at the beginning. I tell them that's why I take lymph nodes. And we're going to harvest your lymph nodes because we want to look at them at a microscope, because if there's disease in there, we're going to give you adjuvant therapy. Mm-hmm. I write it down in their little book so they can take it home and they know that. And I think that's important. It lets them know why we do what we do and that this is a possibility. Granted, my PAs hate it because everyone calls asking for their path the minute they leave the hospital.
Yeah, that's true.
Yeah. Are there any studies looking at patients who might increase indication for surgery after neoadjuvant, for example, multi-zone N2, N3 disease? Thank you. So I don't think we've really gone into that multi-station N2 or not. That's where, where it all becomes controversial. And I know there is a trial that's looking at N3. I don't think we've gotten that sophisticated. Again, those are the kind of things I hope we can find more out about. If we're able to put all these neoadjuvant and peri-adjuvant trials together, we might have that information. Yeah. Is that Dr. Broderick?
Hi. Thanks for doing this. Very informative. One logistical question, maybe for both of you, practicing in 2 different healthcare systems. When are you trying to time your resection after chemo-IO, and do you think it matters for technical feasibility? And when are you re-imaging? At what point after treatment?
So I just had a discussion this morning. We tend to, where I am, not to be super early. It's rare that I get someone in within 4 weeks to surgery. That's kind of when we get them back, we restage them, I redo their PFTs. We do often see a drop in PFTs with induction therapy. I think it's actually the chemo, not the IO, that does it. And we try to get them done in that kind of 6 to 12 week window. But in someone who has a drop in PFTs, we definitely wait. I think those patients might have a risk for pneumonitis and such, and we really give them time. And I haven't seen an increased complication in those patients who we do have to wait for physiologic reasons past 12 weeks. So this is not chemoradiation. I don't know the good and bad of waiting that long, but I think that line was set up for a very different treatment.
Yeah, so we tend to aim 4 to 6 weeks. Sometimes it goes out to 8. So same within that range, I haven't noticed a difference. It's sort of a completely different beast than the oligometastatic patients that are all frozen. I'm sure you're familiar with. But so that's the range within we try to operate. I like to get the restaging scan after as much therapy as possible, so about a week after the 3rd cycle. But for those patients that are more borderline, where we've kind of agreed it as a tumor board that they might still go down the line of chemorads. Not that I'm advocating that that's the current standard, but we do that for some cases. Then we'll re-image after 2 cycles.
Yeah, I'm in the 4 to 6 week camp as well, and the few people who I've postponed, mostly because of IO complications, I find that it's harder.
Yeah.
That hilum is just a lot more difficult to deal with. The other second question I had is there anyone, or are there situations in which you would give chemo-IO and potentially based on radiographic response or even restaging, omit surgery in that person's paradigm?
I still don't have confidence in what the radiologic responses mean in terms of pathology. I just don't think they line up yet, so I have never omitted surgery for what I found on a scan. I may have had to omit surgery because I've made a bad decision about whether they were resectable or not, and that's usually a physiologic error I've made.
Yeah.
But I don't think I've ever changed my treatment approach based upon rescanning.
I can think of one patient, and she was actually N3 and had a categorical stance against RT. She refused RT. I told her that would be the appropriate approach, and so she won neoadjuvant therapy. And I mean, she turned out to have a radiographic CR, and I just couldn't we re-EBUSed her, and there was no disease on the EBUS. So that is one patient I have in my practice currently under surveillance who we didn't operate on. But it wouldn't be something I would advocate for at this stage yet.
No, I'm in the same boat. I just have 2 folks who probably would have needed a right pneumonectomy and had essentially a complete radiographic response and have refused. They
Right.
said, I don't want it. And so we're under surveillance. One's a year out, the other's only 6 months now. We'll see how it goes.
As much as I love a good past CR, and I really do think it feels great, the one that I didn't love was the one I did a pneumonectomy for. That's a little bit of a hollow feeling.
Mm-hmm.
Thanks.
Great. Well, thank you very much, everyone.
Thank you all.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/WFQ860. This activity is supported through educational grants from Bristol Myers Squibb and Merck & Company Incorporated.